Hey, we wanted to welcome everyone to our educational webinar on some considerations for extenders, the use of extenders, NPs and PAs. And there are changes to the Medicare requirements specifically for when you are both seeing patients, both the extender and the physician, and how that needs to be appropriately documented and appropriately billed. So we have again Lisa Werner from AOD Fleming, who is I always give Lisa the highest praise, and I will continue to do that because she certainly deserves it, and she does a lot of work for us that is in the background as well as in the foreground, and we appreciate that every day. So Lisa, I'm going to hand it over to you.
Okay, great. I'm going to pull up my slides. Screen share, we'll do desktop. And confirm that you do see the slides up.
Yes, slides are up.
Okay, good. All right, so I don't have many slides to share with you, but I have a couple, and hope and should be all you need, I think, on the topic. But the first one is history. As Dr. Lupinacci said, this is a change that has transpired this year related to Medicare and Medicare reimbursement. Last year, your facility visits could be billed under the NPI of the physician as long as the physician performed some part of the E&M visit. So the practice received full payment for the visit rather than the 85% rate that the physician fee schedule pays for a visit that's completely done by the physician extender. So again, last year, if the doctor took part in the exam or management at all, you could bill it under your NPI and receive 100%. If the non-physician extender did the visit on their own and billed it under their NPI, the reimbursement rate was 85% of what's published in the physician fee schedule. So currently, Medicare has asked us to change the way we do things. And now the split shared visits may be billed under the NPI of the physician or non-physician practitioner who either documents the support of the history, exam, or medical decision-making for the visit, provides more than 50% of the service time. The documentation needs to reflect the physician performed one of the three key components or greater than 50% of the time. So if the physician is billing for the visit, the documentation needs to reflect that the physician was present for critical portions of that E&M visit by documenting the history, exam, or medical decision making. Or the physician needs to document that they were there for greater than 50% of the time. So if you're rounding together and then the extender is writing the note, you have to decide if that took greater than more time than the actual visit with the patient did, so that you end up with a 50% mark. Now, chances are, if you're rounding together, you are going to fall into that greater than 50% of the service time and be able to bill under the physician's NPI. I don't see too many instances where folks are doing that right now, and rather I feel like the time is spent where the physician or the practitioner does some rounding and then spends time with the physician for updates, and the physician does his or her own rounding and maybe finishes the note that has been started by the physician extender. So my advice on that would be, if you're not documenting a significant portion of that visit, then be sure to include the key component in the documentation of greater than 50% of the time was spent by the physician if you intend to bill it under your NPI number. So this is step 1. Step 2 comes next year, when Medicare says split shared visits must be billed under the NPI of the individual who provides greater than 50% of the total visit time. So they're inching us closer to it has to be based on time. So if right now you feel like you're going to be able to get away with billing under the physician's NPI because of the documentation or portions of the documentation that the physician is completing, then know that this is just a stopgap and we're halfway through the year practically. So at the end of this year, in order to bill under your NPI, it's going to be based on 50% of total time. The rule provisions don't apply to office visits. So anything that is billed under Service Code 11 are still billed incident 2. If the requirements are satisfied, which is that it's for an established patient, it's for an established plan of care or condition, and the extender is under direct supervision. It can be reported for new patients as well as established patients for initial encounter, subsequent encounter, critical care, prolonged EM visits, or skilled nursing facilities with a new modifier, and that modifier is FS. But I get the feeling that most of you under US Physiatry are actually billing within the hospital or skilled nursing. So you're not talking about this Service Code 11. Typical practice, the nurse, or I should say non-physician practitioner, completed initial rounds in the hospital. Physician briefly sees each patient later in the day. The physician bills under his or her NPI, and you're getting 100% of the physician fee schedule reimbursement. So the catch is that the physician has not likely spent greater than 50% of total time with the patient or documented all of the note. So the visit currently would be billed under the NPI of the non-physician practitioner, and you're going to receive 80% of the physician fee schedule reimbursement. So things to remember for optimal billing, the first and foremost is this is only about Medicare patients. Now that's a pretty big statement because 80% of the patients in inpatient rehab are Medicare patients. And it does apply to Medicare Advantage plans as well. But we shouldn't start thinking about billing everybody according to Medicare regulations, because that's just inviting the insurance companies to change their ways faster. So really it should only apply to your Medicare claims. If you don't know if it's a Medicare patient, it's worth looking into the chart. I mean, it's always, I do chart reviews all the time in Epic. It's pretty easy to identify what the insurance is for a patient. So if you're using an electronic record, that should be pretty easy to identify. The other thing that I'll give out as a tip is be sure that if you think the physician practitioner is or non-physician practitioner is doing the billing, so thus you're using their NPI, be sure you don't get caught with them not having an active enrollment. So certainly within your company, I'm sure that there's somebody making sure that folks are enrolled, but just don't take it for granted. Other thing, select codes based on time or the E&M guidelines. Take advantage of whatever we can for the remainder of this year before everything shifts over to that exceeding 50% of the time being spent by the physician in order to bill and get paid 100%. So a lot of you guys have gotten used to the billing based on time idea for your daily visits. If I've done a review of your charts, you've probably heard from me that it is important to document how much time is spent in the total visit. And then there is that 50% mark that we're looking at regarding billing based on time too, where you say greater than 50% of the time was spent in care coordination or counseling and the topics that you covered. So we're already thinking time. That's one step in the right direction here. but don't just rely on that and shortchange yourself if what you've done regarding documentation of medical decision making is significant and would warrant billing under your own NPI in the remaining 7 months of the year. So I did throw in these slides that if you've attended the webinars are not new and different. You've seen them before, just to remind you of what goes into the E&M code and what E&M codes are available. This is for initial inpatients. And I'm really going to highlight today the minutes where I like for you to think about how complex the visit is in order to help identify the correct time. But if we're talking about greater than 50% of the service time being spent by the physician in order to bill under the physician's NPI, I think it's also important to understand the thresholds that go with that time. So for a new patient, if you're billing the lowest E&M service code for the initial HMP, that typically means it took you about 30 minutes. The middle level is about 50 minutes, and the highest level is 70 minutes. Remember that this does incorporate all of the time that you're spending with the patient, doing your exam of the patient. It also involves any chart review, talking to other service providers, which might be other physicians on the case, it might be the nurses, it might be the therapists. And then it could be family members who are present and have questions for you. But when you go to determine which code is appropriate, all of that time should be considered. So you may see a patient, and by and large, on the initial HMPs that I review, I have no qualms about saying that the history and physical exam are comprehensive. Templates cover you in that regard. And it's the first time you're documenting it. So chances are good you've got a good history of present illness. You've got information about the patient's social history or past medical history, any kind of issues they have had, issues in their family. So that covers you for comprehensive history. The physical exam needs to have at least 7 points in it to be considered comprehensive. And templates, again, nail that for you. So you shouldn't have any qualms about the comprehensive nature. The medical decision making at the complexity of it is usually the decision point for whether I think you should be billing out the 99222 or the 99223. If you are looking at patients who have several comorbidities that are requiring monitoring and management, in addition to the main reason that brought them to inpatient rehab, you're probably going to fall into that high complexity category, especially if one of them is pain management, because the use of narcotics, as long as there's management of that, generally constitutes high complexity in the medical decision-making realm. So not surprisingly, I do see most of the initial HMP visits billed out at that 99223 level. So 70 minutes or all of these components. But if you think about the 70 minutes and you're trying to figure out if you're doing these HMPs with the use of a physician extender, where does that line, where are you drawing that line of, did I spend more time or did the practitioner spend more time? I think it's good to have in mind how much time did I spend anyway? And 70 minutes is probably not a hard benchmark to achieve. As far as follow-up visits go, our thresholds are 15 minutes, 25 minutes, and 35 minutes. Definitely when there is a team conference involved in inpatient rehab, you may not be dealing with high complexity issues, and most of your other visits potentially have been billed out at a moderate complexity level. But when you're adding in that 10 or so extra minutes that comes with discussing a patient in team conference, you should be comfortable billing out at that higher level billing code because you're meeting that 35-minute threshold in addition to the rounding and note writing that you've done earlier or maybe later in the day for that same patient. So again, we're trying to figure out which percentage of that visit was managed by the physician extender versus the physician. And if the physician has done more than 50% of the time or has documented on the medical decision making, history, or physical exam, and that constitutes the significant portion of it, then you can bill under the physician's NPI. That gets us through till the end of December, after which time it will be 100% based on the time that each of you spends. Next up, the SNF codes look similar. The time thresholds are not as stringent as inpatient rehab. So we have 3 levels for initial encounters. They're based on 25 minutes, 35 minutes, 45 minutes. And the subsequent service codes are based on 10, 15, 25, and 35. So I do have in here slides that you have seen again on other occasions about what goes into the history. I really did talk about several of these things as we went through the earlier slides, but good reference for how do you know if your history is significant enough. Problem focused, which is the lowest level of the billing code, there are no specific requirements. So basically, if you don't have anything except why the patient's coming, you're probably a problem focused history level. Expanded problem focused is talking about the status of 1 to 2 chronic conditions, a brief history of the patient's present illness, pertinent problems covering at least 1 system, and it would not include past medical history, family, or social history. Detailed is where detailed and comprehensive is where I see the most information in notes, and luckily a lot of this pulls through, so you're seeing it. If you're including it in your H&P, you're probably also seeing some of this pulled through to your progress notes. But the detailed history is an extended review of systems, requires 2 to 9 systems, pertinent history in one of the areas, and no specific HPI elements are required. So at this point, if you're saying why the patient came to rehab, and then you're talking about some of the history of the hospitalization that touches on 2 to 9 systems, or if your template outlines 2 to 9 systems that you're commenting on, you're good for detailed. Comprehensive, status of 3 chronic conditions, an extended HPI, which is considered to be 4 or more, and a complete review of systems, which is 10 or more systems, or the pertinent positive and negative of some systems with the statements of all others negative. So you are allowed to do your exam, but not document on every one of those 10 points. If nothing's changed, it's okay to say all others negative and just comment on the ones that have changed. And then a complete past medical, family, social history is required. The exam, much more straightforward, problem focused. You're really not talking about very much, 1 body system, expanded up to 7, detailed up to 7. So if you're going to ask me the question of is it expanded, problem focused, and detailed, I don't really know, since it's the same for either one. So I usually give credit for detailed, and comprehensive as 8 or more. This is a list of body areas and systems that count toward the components. And then lastly, the medical decision. This is all a point system, and I've been through this point system on other webinars, and it's really convoluted. I chose not to include all of the slides in this presentation, but want to remind you that it's based on the number of diagnoses and treatment options for the patient, risk of complications and or morbidity or mortality, and the amount or complexity of data reviewed, and lastly, overall decision making. So if you feel like you've got a patient who's got a lot going on, they have high risk comorbidities, you're reviewing a lot of information and having to make changes based on what you're seeing during your exam of the patient, you're probably at a high level of decision making. Let's hope your patients don't stay that way throughout the entire inpatient rehab stay or skilled nursing stay. Hopefully we're stabilizing them, and at some point, while it may take more time because the family has more questions about going home and or you're giving more guidance to the nursing staff or therapy staff as they are educating and preparing the family to go home, hopefully the complexity is coming down, even if the time isn't. But you can choose between time or complexity when it comes to selecting your E&M code. And so this is how the final results would look and how your points would add up. One last reminder, because I never want to talk to you guys and not talk about coding based on time, because I think that especially in that scenario that I just gave at the end, you know, sometimes the patient's complexity is getting to be more stable, easier to manage, not as much going on, but your time commitment isn't changing, just because there are more factors at play that you're being called on to comment on or participate in decision making on. So don't hesitate to cover your time spent. I always like to think of our billing codes as the way to justify the importance of the role of the physician, the therapist in that patient's life. And if we devalue ourselves, that's going out on the cost report as far as the therapy services go. It's going out in your billing reports, and ultimately, when we do more and give ourselves credit for less, we are not helping the entire system, and you're not helping yourself. So be sure that you're either documenting very well on the components of the note, or you're covering the time that you're spending in another way, which is documenting, including the amount of time spent, noting that 50% of the visit was spent on care coordination or counseling. And then be sure when you are billing based on time, you include the statement of greater than 50% was spent on care coordination and counseling. You're also including the topics that you covered. I will say the weakest portion of this, as I work with you guys over the years, I'm seeing more documentation, more consistency of this in the documentation. Now what we need to do is take it to that next level and be sure the reasons, the topics covered are documented and they're individualized. I don't think that it's a good practice to have the same statement, the canned text for every patient. You can put a macro in your note so that it shows up there. But at the end of that macro, there needs to be something individualized, something that shows change. It's not believable if you're saying every day I spend 50 minutes and greater than 50% of the time is spent in care coordination and counseling on these topics, and it lists topics that never change. So do yourself a favor and individualize that as much as you possibly can. Okay, so that's it in a nutshell. First couple of slides here, we talked about the fact that when you're splitting visits with a non-physician practitioner, you have the option to bill under the physician's NPI number or the non-physician practitioner's NPI number. If you bill under the physician's number, you're going to get paid 100% of the fee schedule for that visit. But if you bill under the non-physician practitioner's NPI, you're getting 85%. The requirement is the doctor is doing more than half of the work. So depending on how you decide to split your day with a physician practitioner, a non-physician practitioner, you may or may not hit that 50% mark. And if you're below 50% mark, and or if the physician is not or if the physician's not documenting significant portions of the visit, then you're going to have to choose the non-physician practitioner's NPI. If you think this is great, I definitely am doing over half the work, and I'm always documenting on the note, and I'm documenting at least history, physical exam, or the medical decision making, then this year you're good billing under the physician's NPI. Next year, in starting January 1, we're looking at it being based on 50% of the visit alone. So on that note, I can only see my slides, so I'm gonna stop the screen sharing so that I can open it up. I'm happy to take questions. More than anything, I'd love for somebody to comment on what current practices are looking like now. Be happy to talk about where you are, where you see it going in the future, and how to potentially make this work in your favor.
So we have the chat line for anybody that wants to use that. While you're thinking about questions, a couple of comments from me. This presentation will be placed on USP University and within 2 or 3 weeks. So if you haven't used that within the USP website, you can go to the website and log on as a member. That process, I sent a couple of emails. You can call or text me if you want to be reminded of that, but it's pretty straightforward on the website, number one. Number two, I want to run a couple scenarios, Lisa. So we're talking about when January comes and it's greater than 50%. Scenario one would be the physician rounds on a set of patients and the extender rounds on a set of patients. And then it's pretty clear, physician charges theirs, extender charges theirs at 85%. That's like the safest thing to do, I think, in my mind, right? So the other scenario is the physician and the extender rounds and together, and the extender does the documentation. So again, I think that's relatively safe if the documentation has to include, the physician did greater than 51% of the visit because they were there to get it for 100% of the time.
Right.
Seems relatively safe. Then the challenge comes in for those whose practice is the PA rounds first thing in the morning, the physician rounds sometime later, and then the PA does the note, and then they have to document who spent more time. To me, that seems like where the cloudiest thing is going to happen.
I would totally agree with you. And I would assume in that circumstance, the reason you're using a PA, not somebody with a lower skill level than a PA, is because you want the time savings that it's giving you. So they probably are spending more time than the physician is.
Yeah, I mean, I think it's virtually inevitable that they're spending more time, really. So I guess that seems to me, and then the extender is responsible for documenting and that note the amount of time everybody spent. Right. So I think it's going to be hard.
Unless you're not hitting the 50% mark, and then that documentation is unnecessary because you're billing under the NPI that doesn't require that additional documentation.
Right.
So
I get that. That. Yeah, but that would have to be explicit between the physician and the PA's understand, or the extender's understanding of this is what we're doing. You can't tell an extender to do something that's not happening.
Right.
That's my point. So anyways, I just want to clarify the situation because I think those are probably the two most common situations, unless anyone on the conference can think of another paradigm how we use extenders.
One thing I'd like to throw out, because you just triggered my brain to contemplate this, is Medicare, and this is going to affect us for all inpatient. Well, for inpatient rehab, we also have the rule that the physician has to see the patient at least 3 times a week. So your original scenario is divide them in half. Physician does these today and the physician extender does these today. And as long as you're switching off and you're rounding 6 times a week, you're good. Here's the thing, and this is kind of flown under the radar. The first week of the patient's inpatient rehab stay requires the rehab physician to do, well, not even anymore, I shouldn't even say that, requires the rehab physician to see the patient at least 3 times a week. In week 2, the physician extender can participate in one of those 3 required visits. So even if you're just rounding 5 days a week on patients, and then it's a crapshoot as to who's covering on the weekend, and you're switching back and forth, I can't think of a scenario where you're going to be out of compliance with Medicare. Because if the PA happens to be on for Monday, Wednesday, Friday, but the rehab physician sees the patient on Tuesday and Thursday, you've got 5 visits. The rehab physician has done 2 of those. The extender has done the remaining 1, which they're allowed to do, plus 2 extra. So I can tell you, as a consultant to inpatient rehab facilities, I don't advertise this. So right. You may not have heard this in the hospitals where you work, but that is in fact the rule.
Okay. I would not repeat that in my facility, but that's just me. So, okay. Got it.
I see a hand up. I don't know how to do anything about that.
Oh, it's Craig. Craig, go ahead, Craig. Oh, let me see. You in chat?
Yeah.
Hey, no, I was just waiting my turn. My question would be, how does Saturday and Sunday count? I tend to use extenders a lot during the week when I'm spread thin between multiple sites, but I do round quite a bit on Saturday or Sunday. Does the weekend on every patient on a Saturday? Do they include Sunday? How do they count the week? In particular, you just mentioned the first week. If a patient comes in on Thursday, I may see them Thursday and Saturday. If my week ends, then I've only got 2 of the 3 visits.
No, it's Medicare always counts the week starting with the day the patient arrived. So it's a different week for each admission, so to speak, not based on the calendar.
So the other comment I wanted to make was the fact that the 50% is not at this point applicable to commercial insurance. And my personal experience has been, it's very hard for me to keep track of who is commercial and who's Medicare. I guess anyone can change that. Anyone can change their behaviors and how they track it. But I think my own personal experience is the documentation is a little bit burdensome enough where you try to make it uniform rather than non-uniform. But I see what you're saying. I'm just saying from a practical perspective, to change that mindset and doing a number of notes, it can be a bit of a challenge. But, so it is what it is. For sure.
So I will say that your pre-admission screening document ought to lay it out for you. Sometimes we run into issues that they're not correct, but they're more correct than not correct.
Yes.
So if you find that the pre-admission screening has that information buried, regardless of what system you're using, as I say this, I'm probably wrong, but in most scenarios, they're going to have to print that and scan it back into the record at the end. So if it's hard to find on the pre-admission screening, ask the liaisons to write it on the top of the screening form. So then you're not searching for that information, and that probably is a document that you can easily get hands on. So
Yes.
that might help at least put it on your note list so that it
Yes.
starts to get carried over to your daily list that you're carrying around.
Yes, that's all possible. Yes, it is.
I can say for anybody in a select facility, they haven't made it easy, because they've made it easy for a reviewer who looks at that pre-admission screening and gets a snapshot of the most important things they have to say about the patient. But then the demographic information is like 3 pages back. So in that scenario, those are the ones that I'd be thinking about. I know they're printing and scanning them into Epic. So have the liaison write on the top, or the admissions coordinator right on the top of that form what the insurance is.
Any other questions or comments from the group? All right, well, thank you all very much for your Friday afternoon time. As